Yeah, this is Dr. Tom Knutson. Recently relocated from Martinsburg, West Virginia, where I was at for 21 years. I'm a combination of Lynchburg and Farmville. Usually I'm in Farmville 3 days a week, 2 days in the office, 1 day at surgery, and then the other days are in Lynchburg. One of the things we're covering today is knee pain and kind of specifically common knee injuries. What we'll focus on first is meniscal injuries, because that is something that, again, is very common in all age groups. When we first look at things, what you want to look at is the anatomy. So you have one on the inside, which is your medial side, and one on the outside, which is your lateral meniscus. As you can see from the slides, there's what they call a red zone and a white zone. The white zone basically has no blood supply. It gets a lot of its nutrition from the joint fluid itself. The red zone does have a good blood supply, and that is an area that gets its blood flow from the vessels around the knee itself. What a meniscus does, it basically is a protector for the knee joint. So it takes a lot of the stress off the knee joint bone. So definitely the more meniscus you have, the better off for you long term. And one thing that was probably on that slide too, he talked about there's different types of meniscal tears. You can have a horizontal, you can have a vertical, a flat tear, and some of them have different ways they present themselves. But again, it's a very common injury when you talk about meniscal tears. There's two kind of major times in everybody's life when you get them. One is from about 15 to 30, and then it skips a little time, and then from about 40 to 70. But again, it's probably the most common knee injury out there. As you can tell, when you're younger, of course, it's going to be more of a sports injury, and as you get older, it's probably going to be more some recreational sports. It could be also just even everyday activities of life and even working. As a clinician, when you approach someone in the office, first thing you're looking at is your history. So one, how long has the pain been? What kind of symptoms do you have? Do you have locking? Do you have catching? Do you have pain going up and down stairs? Common with a meniscal tear, you'll have instability symptoms, where I kind of describe it as you just don't trust your knee. You can have swelling. As a general rule, with a meniscal tear, the pain comes and goes. You can have a good day or a good week, and then you may have it sometimes where it doesn't bother you. This is a little different than arthritic pain, which usually arthritic pain is pretty consistent. It's day to day. And as we're doing a history on patients, you kind of get a feel for, is this a meniscal tear? Is this arthritis, or what else is going on? Other history that's important is your health. If it's something, and if we're thinking down the road, can you go through surgery? Are you healthy enough to go through surgery? Are you on blood thinners? Have you had any other, again, you have stimulators, things like that like implants for heart. Those are things we all think about, not only for treating this, but also to see even if you're a candidate to have an MRI, which we'll talk about a little later. But again, all those things, come into factor. One thing we do then, once we get the history, we look at you as a patient. We palpate. Where's most of your pain at? Is it inside, outside? On a knee, you have 4 ligaments. Your medial collateral, lateral collateral. So medial is inside, lateral is outside, and then you have your ACL, anterior cruciate ligament, and your PCL. Other contributors to pain can be your patellar tendon or your quadricep tendon. And patellofemoral compartment, which is the front part of your knee, definitely can be a big pain response for people. So then again, we're palpating, we're looking at where the pain's at. We can also go through different maneuvers of your knee to see if we can try to stimulate what causes the pain. These are called sometimes what they call provocative tests. We're also seeing if you have what your motion's like, is it compared to the other side? Also, do you have any swelling in the knee? Swelling in the knee typically is a response to something going on inside the knee, whether it be arthritis, whether it be a meniscal tear, or even a ligamentous injury. Also with the exam, and this is more in the early stages, if it's something that happened, within a few days, you can have bruising. Typically, that's not something you're going to see on a meniscal tear, but if you have a bad injury, you can see that initially. So again, this just goes through what we kind of just talked about with looking at you as a patient, where the swelling's at, where you're sore at. When you're walking, sometimes we can even tell by the way you walk, but then with the exams, what they call the provocative exams, is typically with you laying down and taking your knee through ranges of motion, again, trying to recreate the pain that you have. That way it kind of helps us as a clinician kind of hone things down and narrows our thought process on what will help you next. And that's what this goes through is a lot of it is knowing what it's not. And that kind of helps us as we're going through the exam and talking to you. In our head, we're weeding through and going through what they call a differential diagnosis of, hey, this is what could be going on, this is not, and from there, that will help us, and initially, typically, anytime I see you, but also any of the fellow OrthoVirginians, we're going to get X-rays initially, because X-rays will show your bony anatomy. It'll tell us what your knee joint looks like, and specifically, we like to have those done weight bearing if you can, because that will tell you, it gives you a better idea of what your knee joint looks like with the stress of your body weight. And then from there, also on X-rays, of course, you're only seeing bony structure. You're not seeing any soft tissue or ligamentous structure. The other thing that this X-rays do show, and definitely if it's something out of the ordinary, like cancer, things like that, sometimes you can see that on X-rays. Of course, that's not the first thing you're thinking about, but it gives you a good initial idea of what is there. Once we look at the X-rays, and again, get an idea of what we're looking for, especially if we're looking for a soft tissue injury, then typically the next step is an MRI. What the MRI will do, again, will show, it gives you a good bony anatomy, but it also gives you a better idea of how bad your arthritis is. It tells us if you have a meniscal tear, if you have a ligament tear. Unfortunately, not everybody can have an MRI. Again, if you have a pacemaker or a spinal cord stimulator, some are compatible with an MRI, some are not. So that's information we get. Also, if you've ever been shot, if you've had shrapnel, whether it be just as a recreational hunter or military, those are things that sometimes allow you not to have an MRI. In those situations, you could have what they call a CT arthrogram, where you actually inject dye in a knee. And I call it kind of a poor man's MRI because it gives you a good highlight of the anatomy, but it's definitely not as much information as an MRI would show. You don't necessarily need to have the MRI for diagnosis, but it definitely helps us in our approach to treatment and also approach for surgeries. And then at that point, once we have all the information, we talk about options. Some of the options, again, depend upon your health. Some people just, unfortunately, because of other health issues, can't go through surgery. And truly, if you're just dealing with more arthritis, you can do a conservative route, which are anti-inflammatories, Advil, Motrin, things like that. Unfortunately, they do have their downsides that can affect your blood pressure. And also they can cause ulcers. So those are things that we talk to you about and kind of give you the warning signs to look for. You can do just your basic RICE, ice elevate compression. You can also, there's some topical anti-inflammatories out there, Voltaren gel, which is very safe. And then as you go down the list, you can do cortisone injections. That is not really for a meniscal tear. That's more typically for arthritic conditions. And then once if those don't work or are not working as long, you can do what they call gel injections or viscosupplementation. With those injections, they can be very effective. However, typically insurances need approval. So we have to get approval through insurance to do those. And typically insurance will want to see that you've gone through some of the other easier steps before we can get authorization for those shots. If you have surgery, I actually tore my meniscus probably about 15 years ago. As a general rule, the surgery lasts about 30 minutes. It is outpatient. You go home that day. You're able to, depending upon if it's just a straightforward meniscal tear, typically you're walking on it that day. Now, I tell people it usually takes about a month before you're back doing most things you want to do. However, you're going to continue to make progress and gains for a good 2 to 3 months after that. I will tell you from my experience, when I went through mine, I was trying to do my exercises faithfully. And at about the 6-week point, I felt I should have been farther along, and I started therapy at that point. Definitely therapy is a great modality. They can teach you a lot of things. They can encourage you to push through some of the pain that is kind of normal after surgery. As a general rule, I don't start therapy right away. Usually I kind of see how you're doing at 2 weeks. And then after that, and depending upon the conversation, whether we get you right into therapy or not. But again, that is definitely a nice tool to have. But again, you are up walking day one, but it's not something, unfortunately, it's not an instant fix. So it does take some time as you continue to get your strength back and your mobility back. Any questions?
Thank you so much. We do have questions coming in. Some of the questions were submitted ahead of time. Some of the questions are coming in live. So if you are watching live, you are welcome to leave a question in the comments. We will get to as many as we have time for. So our first question is, if you have had significant knee pain for several months, should you make an appointment to see a doctor or make an appointment for physical therapy first?
I would start with a doctor first for a couple of reasons. Typically, to get a prescription for physical therapy, you're going to need to get that from a physician, whether it be your family doctor or orthopedic surgeon or specialist. So I would start with that visit first. That way they can kind of guide you and direct you. And that way you're not necessarily going to therapy, for no good reason. And not that it wouldn't help you, but that way you can have the therapy more directed toward what your needs are.
Thank you. How do you strengthen your knee to avoid further damage after it's already been injured?
A lot of it is, first things first, to start walking. I typically will tell people to do low impact activities, whether it be bike, elliptical, Stairmaster. Again, from my experience, I was at the time running, and it really took me a good 3 to 4 months before I was comfortable running again. So you want to get just your normal walk back. Then you can start doing leg extension, leg curls in a weight room or weight machine. You can do even just what they call body weight squats, where you're just almost like sitting down, standing up. With that, you want to be careful on how low you go. Typically, I don't encourage you to go any lower than 90, and sometimes even that's too low. And you also want to work on the affected side more so than your good side. So, for example, if you're doing sets with exercises, you want to do 2 for your bad side, 1 for your good side. The other thing to think about too is you don't want to strengthen every day. You want to strengthen about 3 days a week. If you strengthen every day, you're going to get to the point where that muscle gets fatigued, and you may, not that you're going to do any harm, but you may start getting more painful, and the benefits aren't as, the downsides worse than the benefits.
Thank you. Is regular massage good for arthritis in the knee?
It can definitely help. Of course, it's not going to make your arthritis go away, but it can help with your symptoms. It can help soften or kind of loosen your musculature up. And also, your massage therapist can go through a good stretching routine, which none of us are good at. That's just something, unfortunately, we don't pay a lot of attention to, but definitely can be a huge benefit. And maybe not make your pain 0, but it can take it from a 5 to a 2 or a 5 to a 3. So make things a lot more tolerable.
Thank you. If we suspect a meniscal tear in somebody, what's the risk of leaving it undiagnosed and untreated?
There's no downside with, and I had a couple situations that either for whatever reason, whether it be vacation or timing or work or whatever, you can't address the meniscal tear at the time. So there's nothing wrong with waiting. The really only downside is you can make if you have another injury on top of that, you can make a small tear bigger. With those, you can still take care of it surgically, but you may end up losing a little bit more meniscus than you would have if you addressed it right away. And also one thing that I think was in the slides that I didn't touch on, when you talk about a meniscectomy versus a meniscal repair. So meniscectomy is when you take out that part that's torn. A meniscal repair is where it's actually going to put sutures in, or there's different techniques, but repairing the meniscus. Unfortunately, not many meniscus are repairable just because of the blood flow. And also your downtime after a meniscal repair is pretty significantly different. You can't walk on it for 6 weeks, and you're limited on your motion for 6 weeks. So sometimes that is also kind of prohibitive on treatment options. Whereas a meniscectomy, you can start walking on it right away. And again, we try to take it a little as you have to, because it does serve a purpose, but you also want to hurt yourself.
Thank you. What causes knee pain that started after a vacation with lots of hiking and stairs?
Most likely you probably did more than you probably are used to, and especially if you're doing a lot of up and down or hiking up and down mountains, that is typically probably more patellofemoral underneath your kneecap. And typically that will subside once you're done that activity. So once you kind of get back to your normal routine, that should take care of itself. But if you have a little bit of arthritis underneath your kneecap, definitely activities like that will make that worse. Or worsen your symptoms, not necessarily make the arthritis worse, but worsen.
Thank you. Are doing squats worth it, or is the strain in the knees not worth the benefits and other leg exercises should be done instead?
I'm not a big fan of squats. I think if you're doing it for a couple of reasons. One, you really should not go, again, below 90 degrees. So basically like a sitting down position. You probably should, I would go to about 45 degrees. Lunges are good with some light weight. Some squats, again, are, if it's controlled, it's not a bad exercise, but unfortunately not a lot of people have very good technique. So you end up hurting other things. Some of the machines in the gym where you don't have a bar across your shoulders, but you're on like a sled. Those are definitely a more controlled exercise. So I guess the take home is if you're going to do it correctly and have good technique.
Thank you. What causes crackling sounds in your knee when you stand up? And is it related to previous knee issues like a previous meniscal tear?
Typically, it's not going to be related to a meniscal tear. It can be if you have some swelling or a little bit of arthritis in your knee. Typically, that's what's going to cause the cracking or grinding sensation. Very common, and just because you have it doesn't mean anything's bad. And so a lot of times it doesn't even cause pain, and in some respects it may even make the pain feel better. But like I said, typically it's either a little bit of early arthritis and or a little bit of swelling in the knee.
Thank you. How can hip and knee pain be related? Can one cause the other one?
Yes. A lot of times if you have, especially like people with arthritic hips, can get referred pain to your knee. And that is based on the nerve distribution around the leg. Again, it's what they call referred pain, and you'll probably see that like even people have had sciatica, even though the problem's in the back, it's going to give you leg pain. So arthritic hip can cause knee pain. Some of it also, if you're if your gait is off, if you're limping because you have a bad hip or even bad back, that can give you knee pain because, again, your cadence or your gait is off.
Thank you. Is there a way to regrow thinning cartilage in the knee?
There are some techniques out there that in certain situations where they can either transplant cartilage, they can either take cartilage from your knee, take it out, regrow it, and put it back in. That works good for certain small, what they call small lesions or small areas. Unfortunately, a lot of those things are not covered by insurance and they're not cheap. And there's also a lot of downtime with regard to being off your knee. You can do stem cell injections, which really necessarily aren't going to regrow cartilage, but they can definitely be beneficial. The tough thing with those, again, those are not cheap. But again, if you have some arthritis, it's not going to, let's say you got a 50-year-old knee, it's not going to give you a 20-year-old knee again, unfortunately. But there are other procedures, what they call cartilage transplant, where you take your own cartilage, and it's almost like getting hair plugs, where you do that for your knee, take cartilage from a certain part of the knee that doesn't need it and put it on places that you are deficient in.
Thank you. Can knee pain radiate up and down the leg? And if so, where would it radiate to?
Usually knee pain is not going to radiate up. I mean, and if it's going to radiate, if it's going to go anywhere, it's going to go down. And usually more along the tendons or ligaments around the knee. It would not typically go past, I would say your tibia is below the knee joint. So it would not go much farther, probably past than half of that, okay? Because it usually preferred pain from the knee is going to be your patellar tendon. It could be your hamstring tendon. It can be your, what they call your IT band, which is on the outside of the knee. So again, usually it's around the knee, but it typically does not go up. If anything, it goes down.
Thank you. What is the difference between the meniscus and cartilage?
So the meniscus is cartilage. It's a different, so you can have your articular cartilage, which is a different type of cartilage than what your meniscus is made out of, but both are considered cartilage.
Thank you. How do the structures in the knee change as we age? A lot of that can be, and I will tell you, this is kind of a generality, but as a general rule, ladies are more knock-kneed, guys are more bow-legged. So that changes your stresses. So the more stress, if your stress is more on the outside of the knee, as you get older, you're going to get arthritis on that part of your knee. And as like, or if you're more bow-legged, you're going to have more stress along the inside of the knee. And again, that's going to put more stress and cause a little bit more arthritic changes on the inside of the knee. Some of it could also be what they call patellofemoral around the kneecap. So if your kneecap is not perfectly aligned, that can also put stress on one part of the kneecap more than the other. And unfortunately, all of those things come with time, come with injuries. Weight can play a factor as well. All right. Thank you so much. That is all the time that we have for today. Dr. Knutson, would you like to close?
Appreciate all the good questions. Definitely, if you're having some nagging injuries, we're here for you, whether it be here in Farmville or in Lynchburg. Thank you.